Dr. Ashwini Setya from Max Superspeciality Hospital, Delhi. He is a gastroenterologist and a medical legal consultant and advisor. He will be our first speaker. He has done his MD, DM, Gastroenterology, P.G.D.M.L.S, and he has many things to his sleeves. Organized 3 national conferences. He has got one of the best gastroenterologist award in Northern India by Prevention and India Today Group magazine for 3 years. Today he will be here to talk about the deficiencies in consent taking. This is a medical legal topic, though he is a gastroenterologist, but also a medical legal expert. Dr. Ashwini Setya, please share your screen and unmute yourself.
Thank you, Dr.Shirohi, for those kind words. This has come, I think it was the end. Just one second. Why is it coming towards the end? I don't know.
Sir, just press escape. Press escape. I'll just tell you.
No, it is. I have done that.
Yes. No. Now you have to select the first slide. Select this slide. No. Now do play the slideshow. It will come properly now.
I did that. Thank you.
Okay.
So I was asked by Dr. Anurag Verma to speak in this webinar, and he said, "Ji, aapko jo man kare wo kar dena." And finally, he said that, okay, you could speak on consent. Consent is such a large topic in itself that I won't be able to do justice in few minutes. So I pick up what we find commonly, what deficiencies in consent are found commonly. So before we go further, let us see how important it is. And I'm quoting an article by Dr. Neeraj Nagpal, who's sitting amongst us today, who found, and it was published in Indian Journal of Gastroenterology in 2017, that one of the major shortcomings leading to awards against the gastroenterologist was lack of proper consent. Almost 60% cases where the award was given, it was because of lack of proper consent. Let's see what consent is before we go on to what the deficiencies are. Consent is something when 2 or more persons are said to consent when they agree upon the same thing in the same sense. That is, parties ad idem, which means that I also understand that 2 plus 2 are 4, and you also understand that 2 plus 2 are 4. Agreement, consent, and contract, they are interrelated terms. We'll come to it by and see how they are. I have a disclaimer that what follows are the most commonly found deficiencies in consent. It is not claimed to be an exhaustive list. Deficiency in consent. The biggest deficiency in consent can be that no written consent for procedures, invasive procedures and surgeries was taken. And if that is the case, consider yourself doomed. No consent, no defense. So I am citing one case, which is although a case of 2003, but was decided by the State Consumer Dispute Redressal Commission of Maharashtra in April 2018, where the plaintiff was also a surgeon and the doctor was also a surgeon. But deficiency of service was established. Why? Because written consent of the complainant was not obtained. In fact, there was no document on record giving the details of the procedure done, either as OPD or otherwise. So finally, defendant was ordered to pay 50,000 towards cost, 2,59,428 towards the surgery bill which he had to undergo later, and 10 lakhs for mental agony. Remember, this is when there is no deficiency in, there is no negligence in the treatment. What is the principle relating to consent? Why it is important? Because every human being of adult years and a sound mind has a right to determine what should be done with his body. And a surgeon who intends to perform the operation without consent commits an assault for which he is liable in damages. Who only intends. If he does it, which means any intentional touching of a person is unlawful and amounts to the tort of battery, unless it is justified by consent or other lawful authority. What is the deficiency we see very commonly? And this particular case, which I'm going to cite, is for the generic or general or blanket consent in a printed form. The judgment was delivered by National Commission as late as just about 2 months ago. This was on the basis of entire medical record, and again we find that there was no deficiency in service or medical negligence in this case. But this was deemed to be an unfair trade practice within the meaning of section 2(1)R of the Act 1986, wherein it was found that the uniform use of pre-printed and fixed informed consent cum undertaking was used and the consent was taken on that. So the court frowned upon it because there was nothing specific in it. Although there's a lot of controversy that has erupted and people are thinking of going to the Supreme Court, etc. But there are two views about it, that some people say that this was not interpreted properly. Others feel that, well, this was a case which was in probably 2007. By that time, Samira Kohli versus Prabha Manchanda judgment had not come and the guideline by the Supreme Court had not been given. So although there is controversy, but point I'm trying to make is that the pre-printed and fixed are to be fixed consent forms are to be denounced. Again, what is the principle? Consent has to be specific in every respect. That is, it should have details of the procedure, the name of the procedure indication, associated risks and additional risks in case of comorbid conditions, available alternatives, chances of failure, and consequences of refusal. They must be specified. Name of the surgeon or physician or team must be mentioned on the form itself. That also specified. What I want to tell you is that the correctness or appropriateness of the treatment procedure does not make the treatment legal in the absence of consent for that treatment. What are the other deficiencies that we find? Consent from someone other than the patient. Now, this probably, to my mind, and as I see it in my experience, this probably is the commonest of the deficiencies that we see. The consent is taken from the attendant, from the relative, from mother, father, spouse, sister, anybody but the patient himself. Whereas the fact is that it is only the patient who should give the consent and nobody else, if he's compos mentis. We'll come to the proxy consent later. This is the case Ram Gopal Varshney versus Laser Site India Private Limited, wherein a cataract surgery was done. And again, once again, I'm underscoring that there was no deficiency or no negligence found in the treatment per se. The claim was awarded purely because consent was of grandson only and not the patient. Another common deficiency that we find is that there is no witness to the consent. Ideally, a witness should be preferably not from the hospital or the treating team staff, either the staff nurse who's attending there or another GDA who's there. Ideally, it should be a neutral, non-partisan witness. But I think if it is from the family or side of the patient, that is good, because then it is clear that he also understands what the patient is undergoing. Especially now with the medical tourism, in case an interpreter has been engaged, he must also sign the consent as witness, not only as witness, but also saying that, okay, he has understood what the doctor has said and conveyed it to in the same terms to the patient. And patient therefore understands and gives his consent. What does the Supreme Court say? Consent of the patient before commencing a treatment should be real and valid. We'll come to real and valid a little later. It should be voluntary, and no one else can consent on behalf of patient unless the patient is minor or insane. That means he's not compos mentis. I have put an asterisk here because there is a conflict. Conflict is in the ethics regulations of Indian Medical Council, Professional Conduct, Etiquette and Ethics Regulations 2002, Chapter 7, Clause 16, wherein it is mentioned, before performing an operation, the physician should obtain in writing the consent from the husband or wife, parent or guardian, as the case may be. Now, this is something which was published in 2002. And the Supreme Court guidelines would definitely override, not only because it was published later, but because whatever Supreme Court says is one of the sources of law. So this is the law of the land. Therefore, this is overridden. I had mentioned real and valid. Let us see what is a valid consent. A legally enforceable agreement becomes a contract which gains validity by free consent, which means a consent which is not caused by coercion, undue influence, fraud, misrepresentation, and mistake, either of fact or of law. Parties should be competent to contract, which means they should be adult and compos mentis, as I mentioned, that for a lawful consideration and lawful object. You cannot draw a contract to murder somebody, or you cannot have a contract or consent for euthanasia. And they are not to be declared void in the legal terms. What are the other deficiencies that we see? Inadequate information and risks not explained, and chances of failure not disclosed. I would take you back again to the same case, the first one which I cited, Dr. Ramesh Kulkarni versus Dr. Medeo. Here, the consent for ERCP, etc., was not taken because, according to the defendant, the patient himself was a surgeon. But we are not going into this right now. What we are saying is that, according to the complainant, the information was not given at all. Forget adequate information. And as far as the chances of failure are concerned, the defendant said that the procedure was done as per world-class standards. Now, that does not say that the chances of failure have been disclosed or have been specified. So, what is the principle applied here is adequate information should contain nature and procedure of treatment, purpose of treatment, benefits and effects of the treatment, alternatives if any available, an outline of substantial risks, adverse consequences of refusing treatment. And information should be of that extent which is accepted as normal and proper by a body of medical men skilled and experienced in the particular field. That is, Boehlem's law is applicable. That is why I insist and I request and I say that there is a need for developing a common consent for routine surgeries, routine operations by the national organization, national bodies. For example, a consent for an endoscopy, upper GI endoscopy, colonoscopy, or other GI endoscopic procedures should be developed by Indian Society of Gastroenterology. And similarly, FOGSI should take care of the consent wherein the gynae procedures and surgeries are done, etc., etc. Because remember, the court has to go by only something which are either a part of guideline or textbook or literature or SOP of a institution. Even that is fine. See, the only exception to the principles of adequate information are genuine emergency, patient is unconscious, and very important, therapeutic privilege, which can be misused sometimes, but it comes to the defense of the defendant. Where the information would be harmful to the patient, for example, where it might cause psychological damages, or where the patient would become so emotionally distraught so as to prevent a rational decision on his part. Which means, again, finally, it only says that the patient no longer remains compos mentis. What risk information should be given? We must explain and record the most commonly occurring risks in the consent. All risks having probability of 10% or more must be specifically spelled out to the patient and duly enlisted in the consent. The exact percentage may not be disclosed, may not be specified, and there is no need to explain remote or theoretical risks because that may frighten or confuse the patient, and he may finally refuse the consent, which will come to his detriment because he is finally refusing the necessary treatment. Similarly, there is no need to explain remote or theoretical risks of refusal because that will persuade the patient to undergo unnecessary treatment or a treatment where the risks may be more or he may eventually not benefit. So the whole idea is that a balance should be achieved. Let us see what we normally see, we commonly see, not normally, commonly we see. That consent is taken by a staff nurse as a routine and she only signs it. She is not allowed to do that and this consent becomes invalid. However, if the doctor, the surgeon, the physician has explained to the patient about the consent, let's say some other time, then some other time means the previous evening or in the morning of the procedure, then an assistant doctor of the team can take a consent. Again, a very commonly observed thing is that consent is taken in a jiffy on the OT table. Consent taken on OT table would be deemed as taken under duress. The complainant may actually take that. And the patient should be given reasonable time to dwell on the subject unless it is dire emergency. For example, there is a cesarean. You can't ask the patient to take, say, 2 hours to decide that. Or there is an impending need of mechanical ventilation, etc. Someone other than the specified doctor does the procedure. As I mentioned earlier, if without the information somebody else does, which means without the consent somebody else does as understood by the patient, then the proxy doctor would be liable for assault and battery both. Unless again, there is an emergency situation. If it is so, then that needs to be recorded in the records as well as in the consent. Someone other than the surgeon takes care in post-operative period. Now, this is a fairly common situation that occurs, especially in workshops wherein an expert is brought from outside, he operates and goes away. Especially in cases when there is an emergency with the doctor and he or she has to leave station. Or there may be other reason where the doctor cannot be present again in that post-operative period. In that particular case, record specifically in consent form for what duration the surgeon or the doctor has agreed to manage the patient, either only for surgery or for post-operative period, etc. Now, this clause may not apply to public hospitals and for those who are doing a group practice, which is another advantage of group practice. Again, there are multiple cases where the claims have been awarded. The deficiencies in consent are deviating from the consented procedure, doing a surgery in addition to or other than consented for. This particular case, Mrs. Chandok versus Gangaram Hospital, a patient with dysfunctional uterine bleeding with 2 previous cesarean sections was scheduled for total abdominal hysterectomy. But on the table, the surgeon decided to do vaginal hysterectomy. And laparotomy ensued because there was bleeding from the ovarian stump and ultimately the patient needed nephrectomy. Again, I stress on the feature that the judgment is that there is no negligence in treating. Bleeding is not negligence because it can occur, it is a complication. But deviation from the route not acceptable without consent. The only proviso is unless life-saving. I've been quoting the Supreme Court from this particular case only. It's Meera Kohli versus Prabha Manchanda, so I'm not going to do the details. All the courts from Supreme Court today and the guidelines, it is this case. Another case similarly was Mrs. Zeba Hamid versus Hajela Hospital, where in a case of primary infertility, consent was taken for diagnostic laparoscopy and hysterectomy, but ovarian drilling and self-injectomy followed, which was without consent, and therefore 25,000 versus plus 2,000 for the cost were awarded. Supreme Court in Prabha Manchanda versus Sameera Kohli said consent given only for diagnostic procedure cannot be considered as consent for therapeutic procedure. Consent given for a specific treatment or procedure will not be valid for any other treatment or procedure. The only exception is, again, very, very important, and this we keep coming across every day. The only exception is where the additional procedure, though unauthorized, is necessary in order to save the life or preserve the health of patient, and it would be unreasonable to delay such unauthorized procedure until patient regains consciousness and takes a decision. There can be a common consent for diagnostic and operative procedures. There can also be a common consent for particular surgical procedure and additional or further procedure that may be required during the course of the surgery. Consent can be taken, as I mentioned earlier, by assistant doctors. One word of caution that do not take blanket consent, as I mentioned earlier, which is general in nature. And in the pre-surgery counseling, please tell the patient and record in the consent if any decision may have to be taken on the operation table. That means you prepare the patient beforehand. After opening the patient, even if it is, let us say that you open, for example, in case of cancer or tuberculosis, and you know that you may not proceed further, please tell the patient and take consent accordingly. Or if it involves damage or removal of possible damage or removal of important organs, or if there is alternatives that may have to be adopted after opening. So you tell all these and then take a consent. In sterilization surgery, the law demands that the spouse must also consent because it affects both the partners. So you must counsel the patient before taking consent for any family planning procedure, and it is advisable to counsel the spouse and take his consent. Inform the patient and record specifically in the medical record the probability of failure of such procedures, for example, tubectomy. Missing of a period by female patient post-procedure needs to be taken as sign of pre-existing pregnancy. Very important thing again, post-facto consent. Sometimes because something has gone wrong, the surgeon or the doctor concerned takes a consent after the procedure. Consent after the procedure would be construed and deemed as misrepresentation, making it invalid. It may attract a charge of perjury and cheating under Section 193 IPC with up to 7 years of imprisonment, especially in case where thumb impressions are taken in case of unconscious patient or the patient who died on the table. Another thing is, which actually comes to the detriment of these surgeons, is that delay or refusal to consent is recorded nowhere, and unless it is documented, court cannot take any cognizance of it. So it must be recorded, and since the patient sometimes refuses even to sign that, at that particular time take a colleague's or administrator's counter signatures, and the doctor can withdraw in such cases from the patient or transfer the patient in a non-emergency situation if the consent is refused or unusually delayed. Common consent is taken for surgery and anesthesia in one form, especially stating any kind of anesthesia, local / spinal / general. Now, this is not allowed any longer. A separate consent for anesthesia is required because the anesthetic complications and risks are completely different and separate from the surgery. And it should be treated as a separate procedure. Procedure in the terms of procedure, say if you are intubating the patient, etc., and you are giving a spinal, that's a procedure in itself. Here, the principle that is applied, and I'll come back to this earlier, is consent should be real and valid. Now, what is real? Real is a term used in UK to denote informed consent, which we have alluded to earlier. And consent, therefore, is a process of communication requiring the fulfillment of certain established elements like competence, sufficient disclosure, and understanding and volunteering. I will just take a couple of more minutes to tell you something about high-risk consent. You should be taken when the patient is in a critical state, high risk. Removal of any organ or limb is a possibility, and you are proceeding with a surgery or a procedure in spite of abnormal parameters. You are kind of compelled to because of circumstances, and the patient has potential for creating trouble. We all know now which all patients can create trouble. The rate of failure is high or relapse is common. Presence of any comorbid condition that may interfere with the surgery, procedure, or treatment, and the treatment recovery is expected to take a very long time. In the emergencies specifically, please do not wait for consent because it could be detrimental to the patient. Proceed with life-saving treatment or surgery by taking oral consent of the patient, and in appropriate cases, even without consent. Take proxy consent if the relatives or attendants are present at that point, or even from another doctor if there's nobody there, or head of the hospital. If you have to proceed without taking such a consent, duly inform the hospital authorities and record it. So my final slide, ladies and gentlemen, is consent is not a one-off event of signatures on paper, as also not a submission of the patient to a particular treatment, but rather a process of communication. It is then perceived as a proactive process, empowering the patient to consciously decide on what he or she considers best. Thank you very much for your attention.
Thank you, Dr. Ashwini. It was a very nice talk. I think that all must have benefited by the consent taking, and it is such an important thing. We may do anything, but not taking right consent may let us in trouble. Our next speaker is Dr. Neeraj Nagpal, MD. Our next speaker is Dr. Neeraj Nagpal. He is Chairman and Managing Trustee, Medicolegal Action Group, based at Chandigarh. He is ex-President IMA Chandigarh State Branch, Director Hope Gastroenterologist Diagnostic Clinic Chandigarh. He is member ASGE, ESGE, ISG, INSAL, SGEIA. He is a writer, RTI activist, speaker, pioneer in GI endoscopy in North India. I welcome you, Dr. Neeraj. Please start your show.
Thank you, Dr.Sirohi, Dr. Verma. Putting me after Ashwini is a difficult job because he is so lucid in his talks that a comparison is very likely. So let me put this slide first, that when a doctor joins a government scheme finding it fascinating, he is not prepared for his dangers. The topic given to me was MSME. Earlier, I have given talks on this, and I was to some extent critical of the fact that it was being claimed that something active has been done to get doctors into MSME. But now I find, yes, efforts have been made by Indian Medical Association, and doctors have now recently, there is some truth in that. But my point is something different. The scheme may seem very attractive, but there are pitfalls of doctors joining such schemes. When I went to different places to deliver talks, I was asked at that time regarding Ayushman Bharat. Doctors were asking for how to get, there was a race to get themselves empaneled in Ayushman Bharat, and even then I used to raise this issue that it is easy to get in, but then you need to realize what are the problems associated with it. IMA had issued this letter and regarding inclusion of healthcare services, and this was issued on 15th of July. At that time, I was not able to get any concrete notification from the government, but later, Financial Express on August 2nd had reported this, that professionals are now included in CLGS. This is a credit line guarantee scheme meant for MSME firms. So now doctors, chartered accountants, lawyers also can get loan under MSME, Emergency Credit Scheme, as the government has now relaxed the criteria. This was the heading. This eligibility criteria for tapping the 3 lakh crore emergency credit line guarantee scheme was to cover professionals, which it was probably not covering, or it was the awareness was not there, and to enable a much wider pool of businesses to benefit from it. This was all very good, but the fact remains the total amount of funds which were identified for this was not increased. It was kept the same. Only more people were made eligible to take benefit from that. So if there were 1,000 industries earlier or 1,000 establishments earlier to take money out of, let us say, 3 lakhs, now out of the 3 lakhs, there are 100,000 companies or 100,000 industries or 100,000 establishments who are eligible to take from within this 3 lakh subsidy. And the MSME Act actually came in 2006. And the classification of micro, small, and medium enterprise that time given was where investment in equipment does not exceed 10 lakhs. This was a micro enterprise. A small enterprise where investment in equipment was up to 10 lakhs, and from 10 lakhs and up to 2 crores. From 10 lakhs to 2 crores was a small enterprise, and from 2 crores to 5 crore equipment came the definition of a medium enterprise. This was superseded by a notification first issued on 1st of June 2020, and then again it has been issued on 26th of June 2020 in supersession of the notification of 1st June. And now the definition of micro enterprise is that your investment is less than 1 CR and your turnover does not exceed 5 CR. So now, besides investment, a turnover criteria also has been added. So if your turnover is less than 5 CR, you remain a micro enterprise. Similarly, a small enterprise where machinery and equipment does not exceed 10 crore, but the turnover does not exceed 50 crores. A medium enterprise would be where the investment in plant and machinery does not exceed 50 CR, and for these cases, the turnover should not exceed 250 CR. When we expanded the definition so much, so a lot many industries, a lot many enterprises became eligible for benefits under MSME. And all these were looking for a share from the same pie, because that pie had not been increased. So ultimately, if you ask me, what are the advantages of being registered under MSME, specifically if I talk from healthcare point of view? Yes, these are the various advantages which are given. There is protection against delay in payment. Theoretically, I could assume that if I am empaneled with ECHS and ECHS does not make my payments within 6 months, which is the routine for ECHS, under MSME, if I am registered, maybe I can get some benefit through the arbitration mechanism of MSME Act. Then collateral-free loans from banks. This is under Credit Guarantee Trust, which has been established by the government as well as the Prime Minister Employment Generation Plan, which is in vogue now. There is a lower rate of interest on loans from banks. There is a concession in electricity bills. There is a reimbursement of payment for obtaining quality certification. It is specified as ISO certification, but I assume the same principle will be applicable for NABH and others also in case doctors go for it. Exclusive consideration for participating in international domestic trade fairs. Mostly hospitals and doctors would probably not be doing this, but then there is a lot of international influx for treatment in corporate hospitals, and maybe this will also be useful. Stamp duty and octroi benefits, time-bound resolution of disputes with customers through conciliation and arbitration, and even direct tax laws, there is an exemption. Currently, an eligible startup having a turnover of up to 25 crores is allowed deduction of 100% of its profits for 3 consecutive assessment years out of 7 years. This is a huge benefit. Then if you go for cloud computing, there is another subsidy which is there. This micro, small and medium enterprise Samadhan, the delayed payments to MSMEs are taken up in this. The buyer is liable to pay compound interest to supplier on the amount at 3 times the bank rate notified by RBI in case he does not make payment to the supplier for his supplies of goods or services within 45 days. I do not know of a single case where a hospital has taken action against ECHS, CGHS, so many other insurers based on this, but this is an advantage we could use to our benefit. Delayed payment cases are to be decided by the councils which are set up under this act within a period of 90 days. Other benefits, due to MSME registration, bank loans become cheaper and the rate would be around 1 to 1.5% less than what would be available otherwise by an enterprise negotiating directly with the banks. The credit-linked capital subsidy scheme, this a capital subsidy given to business to upgrade and have a better means to do their business. These MSME units can directly approach the banks for these subsidies for technology upgradation by providing 15% upfront capital subsidy up to a maximum of 15 lakhs. This but healthcare, when I go through the list of subsectors which have been specified in this scheme, the healthcare word is not specified in the list of subsectors eligible for credit-linked capital subsidy scheme. But again, a clarification probably would be needed because now the things are in a flux. Credit guarantee for loans up to 2 crores without collateral and third-party guarantee. Anybody who has run an establishment, a medical establishment, would be very much aware of the kind of running we need to do after the banks to get the loans to set up our establishments. And here, under this, credit guarantee for loans without any collateral or third-party guarantee is assured if you are registered under MSME. The guaranteed cover available under the scheme to the extent of 50%, 75%, 80%, and 85% of the sanctioned amount of credit facility. This depends on your eligibility, of course. I'm not going to go into the nitty-gritty of each scheme. Then there is a credit guarantee fund trust for micro and small enterprises for loans up to without collateral or third-party guarantees. The collateral-free loans for term loan working capital facility for a new existing MSME. The fund undertakes to provide guarantee against default and repayment of micro loans extended by lending institutions. The first 5% of the amount in default is borne by a lending institution. The amount above 5%, if applicable, will be settled by the fund to the extent of 50%. So those medical establishments who wish to do something like what Nirav Modi or meaning to say they take a loan and they are not able to repay, there is some kind of a guarantee for the bank to recover some of the amount which is outstanding, the NPA, and from this fund, that kind of a guarantee is there. Then there is something called MSME Cluster Development Program. For healthcare, I have not come across any particular cluster which has been developed so far, but a cluster is a group of enterprises located within an identifiable contiguous area producing same or similar products, complementary products, services, which can be linked together by a common physical infrastructure facilities that help address their common challenges. The concept of a medicity, where multiple hospitals dealing in different super specialities or different specialities could get together and get the government to give them the support under MSME Cluster Development Program. The Government of India grant would be restricted to 70% of the cost of the project, maximum 20 crores for a common facility center, and the cost of project includes the cost of land, building, and working capital. Then there is something called COVID Emergency Credit Line Guarantee Scheme. Borrowers with up to 25 crore outstanding amount as of February 29, 2020 and up to 100 crore annual turnover for financial year 2020 will be eligible for this. Loans sanctioned under this would be up to 20% of the borrower's total outstanding credit as on February 2020. So if you have an outstanding credit of 1 crore on February 29, 2020, you can get a subsidy here of around 20 lakhs. NPA status as on February 29, 2020 shall make the industry not eligible under the scheme. So you should not be an NPA as of February 29. No processing charges, foreclosure prepayment charges once you come under the scheme. No additional collateral requirement for this additional loan which is being given. And the scheme is available basically only up till October 31st, 2020, unless the government extends this. Then the government has also operationalized rupees 20,000 crore stress fund for MSMEs and has issued guidelines to them to avail loans from banks. This subordinate debt scheme to provide financial facility to the stressed MSMEs, the government has created this fund which seeks to extend support to the promoters of operational MSMEs which have become NPA as of April 30th, 2020. So if MSME has become an NPA non-performing asset as of April 30th, they will become eligible for loan here, and the promoters of MSME unit will be given a credit equal to 15% stake in the company or 75 lakh, whichever is lower. This is the guidelines which have been issued. To provide support in respect of restructuring loss-making MSMEs, 90% guarantee coverage would come from the scheme trust and remaining 10% the promoter himself has to give. The scheme is to provide personal loan through banks to the promoters of stressed MSMEs for infusion in the businesses eligible for restructuring as per RBI guidelines. Your business may be going into losses, but it should be eligible for restructuring as per the guidelines which are issued from RBI from time to time. And this financial assistance, as already mentioned, should be up to 15% of the promoter's stake or 75 lakhs, whichever is lower. Units which are SMA2, where payments have been delayed for 61 to 90 days, they are not NPAs, but where payments have been delayed, as well as NPA accounts as of 30th April 2020 can become commercially viable as per assessment of the lending institutions. These also will fall in the to be eligible for benefit under the scheme. Direct tax benefits, Union Budget 2020 defers tax payment on the employee stock option plan. Many startups, especially in the IT sector, give stock options to employees to retain them, and these stock options were taxed. So in 2020, in the MSME sector, the government proposed to defer this tax payment of ESOP by 5 years or till the employees leave the company or sell their shares. The proposed 100% deduction of profit for 3 consecutive assessment year out of 7 for eligible startups having turnover of up to 25 CR. The turnover of up to 25 CR means the micro or small. The government has proposed an increase in the turnover limit of this tax exemption for startups from 25 CR to 100 CR, but it has still not been notified. Next comes the questions, is MSME registration same as Udyog Aadhaar? A lot of doctors were confused because these are misleading terms. Yes, answer is MSME registration has been replaced with Udyog Aadhaar registration. If any micro, small or medium industry wants to start any business, they need to do the registration with MSME Udyog Aadhaar. This registration with MSME can be done in 2 ways, online, offline. This facility provides a business with a lot of facilities, so people should consider. Is Aadhaar card of the person compulsory for this? Yes, for registration under Udyog Aadhaar scheme, Aadhaar card of the person who is the proprietor is compulsory. In case of an applicant other than proprietor, like it is a company or a public limited or a private limited company, then the Aadhaar card of the partners or the directors will be required. Who can register? All forms of concerns: proprietorship, private limited, one-person company, public limited company, trust, limited liability partnership, cooperative society. Any form of concern can register as an MSME. Next question has been asked, can only new ventures be registered or are existing businesses also eligible? Yes, an existing or new business both can apply for MSME or Udyog Aadhaar registrations, provided the existing unit is still functioning and meets the threshold limits of the registration, which I have already mentioned, which were extended as of 26 June 2020. What is the validity of the Udyog Aadhaar certificate? Supposing you have got yourself registered. For all registrations in medical sector, we understand it is for a couple of years or maybe 3 years or 1 year or 2 years. Here, this expiry of this Udyog Aadhaar, there is no expiry of this Udyog Aadhaar certificate. As long as the entity is ethical and financially healthy, there will be no expiry of the certificate. Once you have taken the certificate, that is it. Then, when you register, you will be asked which category under which healthcare is to be included. This is the National Industrial Classification of India 2008, and in the original classification since 2008, human health activities have been included in code 86, hospital activities 861, medical and dental practice activities. These are obviously the professional things which we are now asking doctors to register in MSME. But this was already listed in the National Industrial Classification of India in 2008 under 862. 869 is other human healthcare activities like diagnostic centers, blood bank, even residential care, old age, nursing homes. The point what I was making was, it is easy to get registered to get financial benefits and tax breaks, and even your electricity bills can come down. But once you register with a government agency, there are certain compliances also which become mandatory. And these compliances which become mandatory create problems for doctors, and most of the important things relate to the labor laws which become applicable to all MSMEs. And if you look at that, ESI, Employee Provident Fund, Contract Labor Regulation Abolition Act, Employees Compensation, Equal Remuneration Act, there are innumerable number of acts related to labor laws in India, which you immediately come under once you register yourself as an MSME. And this, then there are a number of environmental laws. Of course, most of them we are anyway following the biomedical waste management rules, the Water Act, the Air Act. The fact remains that these become, once you register, departments other than the health department get involved, and you become a target for various inspections of various departments and under various laws. Look at this. Supreme Court wants private hospitals built on subsidized land to treat poor free. This was Economic Times, July 2018. Why I say joining a government scheme which looks very attractive. There is a lot of subsidy, there are a lot of tax advantages. But once we take these advantages, we also come in for demands of the kind which are not made against other sectors. Supposing I had to install a unit which produced yarn, would I be asked to provide free yarn because I have received subsidy for the land which has been where I have set up the industry? But here in our field, any kind of subsidy or any kind of government help leads us to problems where the expectations from the medical establishments is extremely high. Look at this. Many charitable hospitals in Maharashtra had been given subsidies on medical equipment, land, utility bills, and income tax exemptions without meeting the required obligations of reserving at least 20% of their beds for free. This was one of the websites where internet news from scroll.in on 4th August to 2020. Another example is that of Indraprastha Apollo Hospital in Delhi that was leased land in 1994 for 30 years for a nominal rent of ₹1 per month, on stipulation that it reserves 40% of outpatient treatment and 33% beds for economically weaker section. The hospital, however, did not meet these requirements and was fined by Delhi High Court in 2009 and directed by the Supreme Court to meet its obligations for the poor patients. Then, in India, private corporate hospitals have received government subsidies in various forms, and it in gripping the country. And this was an editorial in Hindu on April 3, 2020. The questions asked were, why is it that the government does not deem it fit to bring them under public control? Does less government mean no accountability even amidst humanitarian crisis? Is it that the overburdened public health services should be made to care for the rising number of needy patients, while most private hospitals remain reserved only for those who can afford to pay? So when we take some kind of a subsidy or some kind of a help from the government, we also expose ourselves to demands which may appear difficult for us to prove. But yes, for youngsters wanting to establish a hospital today, I will strongly recommend that you hire a consultant, go through the provisions of MSME, take whatever advantages you wish to, but keep it in the back of your mind that once we register, we also expose ourselves to certain demands or certain compliances, which then we crib about that we are not able to fulfill. Because we are mostly professionals dealing, couple professionals, husband-wife teams, and once you need to deal with 18, 19 departments for compliances, it becomes difficult for us. And then we start to crib. We forget that we have taken the financial help earlier to establish the same unit. So it is a balance. You have to see whether it is useful for you or not. But yes, there are a lot of advantages. My feeling is it is on paper. Some people will obviously want to go for it. But one thing the government has not done is increased the size of the fund. The fund was 3 lakh crore before, fund is 3 lakh crore now, but you have increased the number of possible eligible people substantially, because 250 crore turnover is a huge amount. So if you wanted so many people to be part of this, then under those circumstances, the corpus of 3 lakh crore should have been increased, which has not been increased. Thank you so very much.
Thank you, Dr. Nagpal. You have made the things very crystal clear. The questions which come to the mind of the people, they have also been answered in your. So I don't think that anything, you have given a very good message to be followed for the coming ones and the existing ones. Thank you, sir. Our next speaker is Dr. Punish Sadana. Dr. Punish Sadana, you please start sharing your screen and unmute yourself. Dr. Punish Sadana is Principal Consultant Cardiology at Max Superspeciality Hospital, Dehradun. He is alumni of BHU and done his DM Cardiology from Savai Mansingh Medical College, Jaipur. He is presently working as Principal Consultant in Max Superspeciality Hospital, Dehradun since May 13. He has performed more than 10,000 diagnostic and therapeutic interventions, including coronary, peripheral, renal angioplasties, pacemakers, AICDs, CRT, and pediatric interventional cardiology procedures. His areas of interest are complex PTCAs, including CTOs and bifurcation angioplasty, and heart failure interventions. His topic for today is COVID infection and cardiovascular implications. Over to you, Dr.
Yeah.
Sadana.
Yeah, good evening, sir, and thank you, Dr.Sirohi, for inviting me to speak in this forum. And we have till now we have listened to two very eminent speakers. One, Dr. Neeraj Nagpal, regarding the inclusion of healthcare into the MSMEs, and other the very important aspect as explained by Dr. Setya regarding the consent part. My talk will be a bit away and it will be more focused on what are the cardiovascular implications of the COVID pandemic that we are facing. Am I audible, sir? Am I audible?
You are audible, sir. You are audible.
Okay, okay. So my topic of discussion today is COVID infection and what are its cardiovascular implications. As we know that coronavirus is a large family of viruses that causes illness ranging from common cold to more severe disease in the past like MERS and SARS. This novel coronavirus, which we are facing nowadays, was identified in 2019 in China. So that's why the disease caused by it is named as COVID-19. The symptoms everybody knows: fever, cough, shortness of breath, headache. These are common symptoms which we face in day-to-day flu also. And as everybody knows how this coronavirus can spread, the virus spreads when the cough droplets of sick person gets transferred to a healthy person, and infected person can transfer the infection to the other things and surfaces like doorknobs, lift buttons, and handrails. And if you touch such contaminated surface and then touch your eyes, nose, or face, this infection can be transferred from a sick person to a healthy person. These are the basic facts how we can avoid to get this infection. That you have to maintain proper hand hygiene. You have to wash your hands frequently, at least with soap and water for at least 20 seconds. And while coughing, cover your face with disposable tissue. There's nothing new, just a repetition of the normal things what we do, like cover your face with a disposable tissue or use a mask and discard them immediately in a waste bin. And don't wear the mask for more than one day. And in the absence of disposable tissues, you may cough or sneeze into your folded elbow. Avoid the handshakes and hugs, and follow the age-old Indian principle of saying namaste for greeting or giving regards to another person. Coming to the clinical context of this COVID-19, this virus was first detected in Wuhan City, China in December 2019. And on March 11, 2020, this was declared as a pandemic throughout the world. The overall case fatality rate is not very high, it's just 2.3%. And more than 80% of the infected patients, they experience mild symptoms and recover without intensive medical intervention. But however, the morbidity and mortality increases with the age. And the published report says that the case fatality rates for comorbid patients are materially higher than the average population. In cancer patient, the fatality rate is 5.6%. In hypertension, it's 6%. And in patients with cardiovascular disease, the case fatality rate is 10.5. It means it is 5 times higher than in a normal patient without any other comorbidities. So it can be more fatal, more morbid type of problems can happen in a patient with associated comorbidities. And more the comorbidities, the fatality rate is very high in such patients. So we have to take very much care of all this group of patients. So how long the patients are infectious? This also everybody knows, but I'm repeating the things. The infectious period means the time you are able to spread the virus to someone else. And for COVID-19, there is emerging evidence to suggest that the infectious periods may start 1 to 3 days before you develop symptoms. And the most infectious period is thought to be 1 to 3 days before symptom starts and in the first 7 days after symptom begin. And but some people may remain infectious for longer also. That's why this a period of quarantine was around 14 to 18 days nowadays. So this is the period in which a patient can be infectious and can spread to a healthy person. Now, coming to the most important aspect, which I was talking about, what are the implications of this COVID infection on cardiovascular care? Patients, those with COVID-19 and pre-existing cardiovascular disease, they have increased risk of severe disease, as I've already told, and death. Mortality is also very high in patients with pre-existing cardiovascular diseases. And coronavirus infection, it has been associated with multiple direct and indirect cardiovascular complications. The most important presentation are arrhythmias. It can be in the form of atrial fibrillation or conduction abnormalities like heart blocks. And the fatal one is ventricular tachycardia and fibrillation. This is mainly due to myocarditis. And the other presentations apart from arrhythmias are acute myocardial injury. Patient can have elevated cardiac troponins like cardiac enzymes, biomarkers of cardiac injury. They can have myocarditis, or the patient can present in frank heart failure. And one very important aspect, which was missed to begin with when this COVID infection starts, that there are a lot of patients who get discharged and they were like hale and hearty at the time of discharge, but suddenly they collapse. The main reason is that it's a very like procoagulant state because of the inflammation by the virus, and patient can develop DVT in the lower limbs, and these thrombus can embolize to pulmonary arteries and can cause major or massive pulmonary embolism leading to death. So patients with a lot of inflammatory markers like D-dimer raised, IL-6 raised, they are usually given uh, uh, low molecular weight heparin in the hospital stay. And after discharge also, if these markers are raised like D-dimer and all, they are given 4 to 6 weeks of oral anticoagulants, the newer anticoagulants also, to prevent this dreaded complication of pulmonary embolism leading to mortality also. The various mechanism has been given for this myocardial injury. A lot of them is still unclear. There are some systemic markers of inflammation, or this virus can affect the heart directly also. So patient can have both direct and indirect due to this pathophysiological changes in the body leading to heart injury. While little is known regarding the effect of COVID-19 on acute coronary syndrome, there are several pathways which has been described. One is like elevation of cardiac markers. This might not be a sign of cardiac acute coronary syndrome. The most important type of myocardial infarction, which is present in this group of patients, is mainly due to supply-demand mismatch. Because of this inflammatory state, patient have increased demand. And if you see the angiography, patient can have ECG findings of acute myocardial infarction. But if you do the angiography in such group of patients, it come out to be normal, because it is not due to the blockage part. It is mainly due to the increased demand due to the inflammatory state of the patient, and blockages are not that significant. So this is very important, what we call as MINOCA, that myocardial infarction with normal coronary arteries. There are a lot of therapies which are under investigation, and now there are some therapies which are established also, like a lot of antivirals. So they can also have a lot of cardiovascular side effects. And the very important part which is missed is that the response to COVID-19 can compromise the rapid rise of non-COVID patients with cardiovascular condition, because most of the hospitals, government or at local level, they're mainly focusing on COVID-19 only nowadays. So there are a lot of other patients who are non-COVID but with cardiovascular conditions, they can be missed. So we have to treat those group of patients also. And the provision of cardiovascular care may place healthcare workers in a position of vulnerability, as we all know that we all are on the front line of face the brunt of this condition, in a position of vulnerability as they become the host or vector of the virus transmission. This is very important. So we have to take care of healthcare professionals also, apart from taking care of the patients. Now, the aspect which I have just spoken, there are a lot of Antivirals like lopinavir, ritonavir, and hydroxychloroquine can cause increase in QT interval, although risk is much more in patients with underlying cardiovascular disease, baseline prolonged QT interval, renal insufficiency, or prolonged exposure to the rhythm problems, leading to rhythm problems. So mainly, especially in patients who have a cardiovascular problem underlying and who are elderly, they should get a baseline ECG done before starting this group of drug to see the baseline QT interval. And there is increased risk of myalgias and myopathies. As one school of thought is saying that colchicine can also be given for the treatment of this COVID infection. And patients who are having underlying cardiovascular problem, they are taking statins. So they both can interact and increase the chances of myalgias and myopathies. And drug interactions of antivirals and blood thinner has also been seen. So a regular monitoring of INR has been advisable. The commonly used antiplatelets apart from aspirin like clopidogrel and ticagrelor, they should be avoided in patients who have been affected by COVID and given antivirals. The other group of antiplatelet like prasugrel, it can be given instead of clopidogrel and ticagrelor. And I'll be speaking in one or more two slides about the ACE inhibitors and ARBs. Most of the people who are of medical fraternity have listened to this thing, that initially the data which have come into the forum was that ACE inhibitors and ARBs, they are harmful for the patients who are infected with COVID, and they even make the patient more prone to COVID infection. But nowadays the results are totally different. They are totally contrasting. Latest trials have shown that ACE inhibitors and ARBs, they are, instead of harming the patient, they are beneficial. The reason which they have given is that the human pathogenic coronavirus bind to the target cells through ACE2 receptors, which is expressed by the epithelial cells of lung, intestine, kidney, and blood vessels. And the expression of ACE2 is increased in diabetic and hypertensive patients who are receiving ACE inhibitors and ARBs. So it has been postulated in the beginning was that the treatment with these drugs will increase the expression of ACE2 and theoretically facilitating the infection with COVID. But clinically speaking, this is not of very much importance. It has been seen that the latest trials have shown that the ARBs enable the increase of available angiotensin 2 by competing with the same receptor, and suggest that increased binding of angiotensin to the catalytic domain of ACE2 could induce a structural change in ACE2 that is unfavorable for COVID-19 binding and its internalization, which was totally in contrast to the previous studies. And ACE2 converts angiotensin 2 to angiotensin 1,7, which has an anti-inflammatory properties, so it is helpful instead of harming the patient. And upregulation of ACE2 by ARBs and ACE inhibitors could enhance this process and ultimately benefit the patient. These are the guidelines given by Cardiological Society of India, which was published in Indian Heart Journal. It says that the medical therapy of heart failure patients, evidence-based management using beta blockers, ACE inhibitors, or ARBs should be continued unless there is any contraindication to the drugs in the patients who are infected with COVID. And patients who develop COVID-19 related myocardial dysfunction may be considered for guideline-directed heart failure therapy, including ACE inhibitors and ARBs. And guideline-directed drug therapy, including ACE inhibitors and ARBs, should be continued in patients with pre-existing heart failure. You should not stop these drugs, and if indicated, you should start these drugs in a patient who is infected with COVID. And this is the similar by American College of Cardiology. It also says that there's no experimental or clinical data demonstrating beneficial or adverse outcome with the background use of ACE inhibitors, ARBs, or other RAS antagonists in COVID-19 infected patients. And patients who are currently prescribed such agents for indications for which these agents are known to be beneficial, they should continue taking this group of drug. This is a flow chart which shows that how to manage how to do a reperfusion strategies in a patient who is infected with COVID, and this in this era of COVID pandemic. I'll not be going into details. I'll be just explaining everything in just 1 or 2 minutes. Patients who are definitely COVID, proven by either by antigen, although this RT-PCR takes some time. Patients who are highly suspected or COVID positive, they should be only treated in a COVID setting only. Patients who are non-COVID, they should always be given an option of thrombolysis also. And patients who are suspected, they should be given an option of thrombolysis and PTCA, primary PTCA, only if proper PPE kit are available in that setting. Otherwise, in an isolated room, instead of giving if PP kits are not available, thrombolysis should be given a first option, because that requires less interaction of a healthcare worker with the patient. So instead of going, even if you have a cath lab facility in your hospital, but this PP kit facility is not up to the mark, better to thrombolyze a patient in an isolated room, so that there is a less interaction of a patient with the doctor, and there is less exposure of the viral load to the healthcare worker. Now, these are the general recommendations for vulnerable patients. To avoid infection, we recommend for a patient that he should continue to take your medication, secure a 1 or 2 month of supply of a medication or longer if possible. Keep a distance of at least 1 meter from the people with a cough or cold or flu. Wash your hands, maintain proper hygiene, and stay at home if possible. Only go outside your home if it is really necessary, and remain aware of your health status. If you experience symptoms of like breathing difficulty, fever, or cough, call your doctor or hospital immediately. Explain to them that you are calling in relation to the new coronavirus and that you are at high risk. These are the general guidelines for heart care at home. People who are who were in lockdown, at home quarantined, or doesn't want to go outside. Eating a balanced diet with a lot of fresh fruits and vegetables, staying hydrated and getting adequate sleep. Daily exercises still must, even if you are staying at home. You can walk between the rooms, walk around when you're on the phone, do simple exercises like squats, planks, and WHO in this group of patients also, in this COVID pandemic era also, the recommendation is same, 150 minutes of moderate exercise per week. If you cannot go out, do it at home. Maintain your social network even remotely, and communicate with your friends and family on regular basis by video call and all. Limit the information you consume. This is very important about the outbreak and time you spend on it, and only trust the reliable sources instead of watching everything on Facebook or relying on Facebook or WhatsApp messages. Avoid using coping strategies involving alcohol or drugs. This is very important, that practice yoga and meditation. It will definitely help. Do not stop your medication on your own, and do teleconsult if needed. Get a flu shot if you are a cardiac patient, and do gardening. It will improve your fitness also and keeps the mood up. And let the sunshine in. Sit in the sun if possible. Thank you, sir.
Thank you, Dr. Sadana, for covering this complex topic in a simple way. I hope it will have been beneficial to all. You end your slide
Sure, sir.
show. Our next speaker will be Dr. Sushma Tomar. Dr. Sushma Tomar is an alumni from MLB Medical College, Jhansi. She did her PG in Obstetrics and Gynae in 1986. She has diploma in advanced endoscopy surgery from Germany, fellowship in in vitro fertilization from Belgium, diploma in medical legal system from Pune, diploma in trichology, cosmetic and aesthetics. She is a consultant at Fortis Hospital, Fortis Hospital at Mumbai, and director of Tomar Nursing Home, IVF and Advanced Endoscopy Center. Our topic for today is optimizing IUI results, best practices. Over to you, Dr. Sushma.
Thanks, Dr. Ashok. After so many important topics with Dr. Ashwin, Dr. Neeraj, and Dr. Punish, actually, as a gynecologist, we are having very limited area to just speak, one room kitchen. So after thinking so many times what I can speak, I thought I will just go on the infertility. That's my interesting topic. So today I will just say a few words how we can, in the infertility patient, how we can optimize the IUI result. As I know, it's not related with everyone. It's the main topic for the gynecologist because infertility is day by day just go on increasing. So we have to, whenever we talk about the infertility, we should know, going to the back our MBBS days, infertility 30% it goes to male partner, 30% to female partner, and 30% to both couple can have any problem, and 10% there is an unexplained infertility. So whenever the couple come after 1 year of staying together without any contraception, we have to investigate the couple, both husband wife, and whatever the reason, we just try to save it, how we can just treat accordingly. So IUI is a very simple procedure. All the gynecologists nowadays in the college, they are having different workshops, so they can just learn and do. And the thing is how we can improve our result of IUI. So once we are talking about the IUI, just say a revision for everyone. Intrauterine deposition of the semen either from the husband or donor in the uterine cavity at the time of ovulation. So it's a very simple and easy procedure that having very minimum learning curve, and all the gynecologists, they can just do it. When we are talking of IUI, we should know the idea behind the IUI is intrauterine insemination, just to expose the oocyte with the more number of sperms at the fallopian tube. So there are more chances to get the fertility. Normal parameter of the from the WHO 2010, there is a revision how much sperm should be there for the minimum IUI. So normal concentration should be more than 15 million, and the motility should be at least more than 32%, when we can think of this is the normal parameter for the IUI. There are different indications for the IUI from both male and female sides. From the male side, when we are talking of oligospermia, when the count is less than 15 million, or there is a asthenospermia or abnormal sperm steatozoospermia is there. So whether the male is having any abnormal factor, male is having any cancer, before going to cancer surgery or chemotherapy or radiation, we used to preserve the semen in the semen bank, and then we can utilize afterward. Or in female, there can be some cervical factor, or there can be the unexplained infertility, or sometimes there is a mild to moderate endometriosis, or there is a unilateral tubal blockage is there because of any infection, whether it's a pox or whether it is gonal or any type of infection. So there are different indications for the IUI. Or many times there is a physical or psychological dysfunction is there. So whether it is a erectile dysfunction or retrograde ejaculation or severe hypospadias or vaginismus, or couple is having the HIV positive. So that are the different indication where we can just use it. Or we are using donors insemination from the semen bank. Authorized semen bank should be there, and all the semen should be properly tested, investigated for the count and for the infection, and then we can use the donor semen. It can be used for the azoospermia patient or severe oligospermia patient where IVF and ICSI is not affordable to the patient, couple is not able to afford because IVF become little costlier affair, or there is a genetic inherited diseases, or there is a single woman. So we have to just see where we can just use it. But whatever we are doing, we have to take the informed consent from the couple and their relative, and we have to just ask them whether they are ready for the donor insemination or they want to go for the ICSI. Like we used to do the testicular aspiration and do the ICSI if they want. But before that, we have to do the testicular biopsy and just check it whether sperms are available or no. So before going the IUI, we have to check many things, whether we are planning for the ovulation cycle, like natural cycle. If patient is having not normal young patient with the normal 28-day cycle, so we can use natural cycle, or we want to have the stimulated cycle, like with the hormones we used to stimulate, or there should be one patent functional tube. Like they are having any infection, even one tube is functioning, then we can use the IUI procedure. Or sometime in the ectopic pregnancy, we used to just remove the one tube, and then in case also we can use the IUI procedure. Or if total sperm count in the male partner is more than 9 million, then also we can do the IUI. So there are different way where we can just use this. Now, counseling is a very important part in any infertility patient. Like first visit, when the couple come for the infertility treatment, we have to investigate properly. We have to do the baseline semen count. We have to do the female hormonal assessment on the baseline on second or third day of the period, do the normal X-ray, HSG, what we were used to do from the college time, do the follicular study, just see whether follicles are developing or no. And then we have to decide, we have to counsel the patient what's the problem and what we can give the option for them, whether they are ready for the IUI, or if very bad condition, they are ready for the donor sperm, or they can have the ICSI if they are willing. So counseling of the couple and family member is very important in the infertility part. When we are doing the counseling, whether gynecologist can do the counseling, or sometimes we are having good educated counselor, they can also do the counseling. But everything should be on the written form, because many time patient, they used to say, हमको समझा नहीं, आपने क्या बताया था, हमारे अंकल को बताइए, आंटी को बताइए, मम्मी को बताइए. So whatever the counseling we are doing, it's always better you write on the paper and then explain in their own language. Like we are in Maharashtra, so most of the patients, they understand the Marathi. So we have to counsel them their own in the IUI procedure. Then we should switch to the IVF. Or they are not affordable, we used to advise them to go for the adoption also. That's all the option we have to tell them ki what problem is your and what option you can have. Now the prognosis of IUI depends on the age of female. If a female is young, less than 30 years, the chances is better because their hormonal level is quite good. If they are having the good BMI below 26, their chances of better because hormones we have to not give in excess quality. Or it depends on the duration of infertility. If they are having very long duration of infertility, the IUI success is going to be down. Or sometimes if there is a single or multiple cause in the female also and the male also, then prognosis is bad. So we have to decide whether what we are going to counsel to the patient, ki how much success rate is there and how many cycles we are just go on trying. So most studies suggested that IUI should be tried before under the age of 40, because after 40, the slowly hormonal level is coming down. They are perimenopausal and we should not give enough time. And if they want in 40, it's always better to go for the IVF. So different lifestyle is also important in the male factor, like male who are having the obesity because of the fat, testicular temperature is high, and because of that, the motility of sperm is coming down, or they are taking tobacco, smoking, alcohol, cocaine, all the any of the addiction like this, the sperm motility is just coming down, or they are exposed to more in the factories, they are exposed to more heat, that is also damaging the sperm. So we should know in male partner what profession they are doing, what addiction they are doing, how much is the weight, how much is lifestyle, everything is important for the male partner. Now, if we are just looking for the IUI, then in the female, we have to just plan it whether we want IUI in the natural cycle or we want to stimulate with the hormones. In hormones, we can use either of gonadotropin, letrose, or gonadotropin injection, clomipene citrate, or we have to plan whether we want the multiple follicle or single one follicle only. What's the endometrial thickness? Whether what trigger we are planning to give. So once we are doing all the baseline hormones level and follicular study in a cycle before, then we can plan accordingly in next cycle for the IUI, what we can plan it. Now, there are different results for the whether we are using the natural cycle or controlled ovarian stimulation with the hormone and what's the male factor is there. So result is dependent on both things, in the male also and the female also. So once we are taking the control ovarian stimulation with the hormones, there are more number of multiple eggs are there and we are getting the better result. And once we are stimulating, we can just plan the time of ovulation. Like when we used to trigger with the SCG, after 36 hours, we have to do IUI. So according to our comfort, according to size of follicles, we can just plan when we can do this IUI. As I said, once we are doing all the hormones at the day 2 or day 3, and we are doing our own baseline TVS sonography, so we can find out how many baseline follicles are there and what's the estrogen level is there. So accordingly, we have to give the stimulation. Antral follicle count give whether this patient is PCOD or going in the hyperstimulation or no. We can just find out what's the cervical length during the IUI, whether it is going to be comfortable or sometimes it's a difficult IUI. Once it is difficult IUI, the chances of success is just coming down. So we should know all the physiology, what we had done in the MBBS level. So it's the same ovulation induction protocol. We should know this ovulation is there on 13 to 18 days in between, and we have to plan our stimulation. Once we are planning stimulation, we should know whether we are planning the monofollicle, single follicle, or we are with the ovarian stimulation, we are planning the multiple follicles. In overall meta-analysis, it has been seen there is a 5% higher pregnancy rate if we are having the 2 follicle, or 8% higher when we are having 3 or 4 follicles are there. So it's always better to do the stimulation and then proceed for the IUI. Now, different drugs are available in the market. Clomipene citrate, since our college time we are just using, but nowadays we used to use the letrose because letrose is not affecting the E2 level and endometrium thickness is good, or letrose with the gonadotropin. So it's gynecologist's choice according to the patient hormonal level, and we give the stimulation. And we have to just see, we should not continue the hormones for a very long time, because if we are giving the clomipene citrate more than 12 months in a lifetime, it's going to cause the late age ovarian cancer. So we have to limit our hormones stimulation. Same stimulation from whatever we are using, the tablet from day 2 to day 6 and 7th, 8th, 9th day, we give the gonadotropin. And once the follicle is developed from 17 to 18 millimeter, we have to trigger with the HCG. And there is 2 ways we can plan the IUI. If we are planning single IUI, then we have to just do the IUI after 36 to 40 hours. Or if we are planning for the double IUI, then we have to do after 24 and 48 hours. So there are different medicines. As I said, letrose nowadays we are using more because single follicle development is there, and endometrium is not going to affect because of this letrose molecule. This again we start from day 2 to day 6 along with gonadotropin, and once the endometrium is more than 9 millimeter, triple line is there, and we just plan for the trigger. So there is a different survey was done, and it was found there was no difference between the anti-estrogen like letrose or with the clomipene citrate. But when we used to add the gonadotropin, the higher pregnancy rate was found along with letrose. So once we are planning for it, it's always better to use the gonadotropin and IUI cycle. But many times we have to cancel our cycle if follicles are more than 4 in 15 millimeter, or if more than 8-10 millimeter, or estrogen level is going to be more than 15 picogram, because then patient is going in the hyperstimulation, and that's a dangerous for the patient. So we used to cancel the cycle. And trigger cycle, once the follicle is mature 18 to 20 millimeter with the SCG, we have to just trigger and plan our time when we have to do IUI. Now, it is many percent, if we are thinking the patient is having the PCOD, we can just trigger with the leupride also. So this gynecologist is the right person to decide what stimulation we have to give to the patient according to the hormone level, and when we have to do it. So other problem is the endometriosis that causes the infertility. So level 1 and level 2 endometriosis, IUI is advisable according to American Society also, and the Asian Fertility Society also. But there should be one patent tube when endometriosis is there, because a lot of adhesions are there and all the pelvic anatomy is disturbed. So we can just do the laparoscopy, see if it is possible, tubes is mobile, and one tube is patent, we can just try with the IUI in grade 1 or grade 2 endometriosis. But if it is going to fail in 2 to 3 cycle, IUI in endometriosis patient, or patient is having frozen pelvis or having the grade 3 and 4 endometriosis, it's always better to go for the IVF, because there is no point to waste time and money in the IUI. So prognosis of IUI is depend on the time of IUI, whether semen is properly collected or no, and if we have instructed husband how to collect it, and what preparation technique we are using, what's the semen count is there, and when we are doing IUI, whether it was easy IUI or it was a difficult IUI, and what type of catheter we are using. So these are the different things on which the IUI success is dependent. Now, as I said before, if we are planning for the single IUI, then 36 to 40 hours after SCG trigger, or we are planning for the double IUI, then 24 and 48 hours after trigger we have to use it. So single IUI act as efficient as the double IUI in idiopathic infertility, but in where the male factor is cause for the infertility, double IUI is definitely going to help it. So all the result is dependent on the sperm preparation, how we are preparing a sperm. According to the sperm preparation, if semen is normal, then we used to do the swim-up method with double layer, or if very low count is there, then density grade method we have to use it, and accordingly we used to prepare it. Insemination, it's always better to do yourself, so you can just do the smooth, and when you are doing sonography, just see the angle, how much is the length of uterus, cervix, and what's the angle for that. And when we are giving any of the stimulation, it's always better to give the progesterone luteal phase support. So semen preparation, as I said, it depends on the type of semen, what method you have to use it. But work at least we should get more than 15 million of sperm when we are just planning it. Cutoff level for the IUI is just 1 million, but we have to see the good motility. If it is more than 30% motile, then we can just try it. We have not to tell to patient to have the abstinence for a long time, because sometimes ovulation time is going to differ. So always a day before only we used to advise the abstinence, and 2 days after IUI we advise them to continue contact. They can do their own routine work also, there is no problem. Only weightlifting, there should not be any sudden jerk that we have to advise to the patient. Semen wash is very important in your lab. It should be proper hygienic way. He has to collect the semen, and proper container should be there, and wash should be done by the experienced embryologist. Maximum pregnancy occur if we are trying in early treatment of the cycle. 88% pregnancy occur in first 3 cycles of IUI, 95% within the 4th cycle. But we should not give more than this trial. For type of catheter is all the catheter look same, but semi-rigid catheter, it works very well because it goes inside smoothly, and there is no bleeding. Once bleeding is there, we are using the rigid, then there is a chances to have the sperm damage, and it should be done in very slow method, 1 to 2 minutes, and we have to just remove it gently in 30 seconds. So only very less amount, 0.3 to 0.5 ml sperms we have to inject, because otherwise it will just come out and the chances of failure will be more. So this is a very simple procedure, but success rate overall after doing all the good procedure, there is a 15 to 20% also only. So we should not just go and pull the patient for a long time, and we have to just try. We will do in 2 or 3 cycle best way what we can do. Even once we are taking the more amount of semen, more than 0.5 ml, the chances of regurgitation is there. It used to come out and the failure become more. Or once sometimes there is a curve, acutely retroverted or acutely antiverted uterus is there, and difficult IUI is there. Then also we have to use some technique, like we have to use the tenepulum for that, or sometimes full bladder we used to use. So all this workup should be done on the day 2 of the period only. Once it is difficult IUI, we are not able to negotiate the internal loss. It's always better. We have to write on the paper that it was difficult. And on next period, on day 2 only, we should do the cervical dilatation. Post IUI, we have to give the progesterone support. That's important because we are doing the stimulation. Otherwise, there is no particular restriction after IUI, so they can have their own normal life or what they are doing at home only. They can have proper diet, everything. Like patient, they used to think of if we are doing bed rest and we are admitting in the hospital, the success rate will be more. So it's not like that. Luteal phase support for the progesterone is very important. So we have to give the support either with the tablet form, vaginal pessary form, gel form, whatever is this gynecologist preference is there. Sometimes if endometrium was thin in early time, then we used to supplement with the estrogen also in the late. So luteal phase depend on whether it was a thin endometrium, normal endometrium, or the thick endometrium. Accordingly, we have to just give it. Sometimes we have to give the HCG 2000. If we are thinking the patient is running late age is there or having less hormone, then we used to use the supplement HCG injection also, 2000 to 5000 unit every 4th day, like in the IVF cycle we used to. IUI used to fail because if we are doing the poor patient selection, there is a timing of IUI is not related to the ovulation, or poor semen preparation is there, or sometimes difficult IUI is there, or sometimes endometrium is not very receptive, so it will fail. So we have to give enough trial till 3 cycle. If it is going to fail, then we should take the next step. IUI should be avoided if both fallopian tube are blocked or severe oligohydrodermatospermia is there, or severe grade 3 and 4 endometriosis is there, or ovarian reserve is there, or more adhesions is there. So in that case, the failure rate is very high. So we should not unnecessarily waste time. So young patient with unsuccessful 3 IUI, we should do the hysterolaparoscopy to find out the biopsy, what's the problem, why she is not conceiving, or otherwise we should proceed for the IVF. So in conclusion, IUI should be considered as first line of treatment for the management of infertility. It's a simple, patient friendly, we have not to admit, and cost effective also, because IVF become very costly and most of the patients, they are not able to afford in 1 or 2 cycles. So we have to just try our best as a gynecologist, see what we can offer them. Thank you.
Thank you, Dr. Sushma. I think I was not aware for the procedure, and many like me may not be aware. Thank you for enlightening us. Now we come to our last speaker, Dr. A.S. Jaggi from Meerut. Dr. Jaggi, you please start sharing your slides. Dr. Sushma, you...
Yeah, I will do it.
Yes. Dr. Jaggi is based at Meerut. He is a senior surgeon, passed his graduation and post-graduation from Lala Lajpat Rai Medical College, Meerut. He has done his fundamentals in critical care support course, which is certified by Society of Critical Care Medicine, California, USA. He did his fellowship in advanced hepatobiliary surgery and liver transplantation from Sir Gangaram Hospital, New Delhi. Successfully, he's done his diploma in hospital management from National Institute of Health and Family Welfare, New Delhi. He is life member of Indian Society of Critical Care Medicine, life member of IMLEA, and many other credits. He will be today speaking on surgeons' perspective in COVID. Welcome, Dr. Jaggi.
Some problem has occurred suddenly. I'll just manage. Just give me a minute, please.
Yes, you have time.
Oh, I'm the last one, so people must be very tired.
No, people are not tired. Yes, you come to your file now.
Something wrong has happened.
Come to your PPT.
I'm just trying that, sir. Something has gone wrong. I don't know. Just now it has gone wrong. While I was trying to share the screen,
you go to your PowerPoint, minimize the zoom and go to your PowerPoint and then open it. Yes, it has come. Yes, we can see it.
that's
We
fine.
can see it.
And you can hear me also?
Yes.
Okay, then. Thank you very much. So friends, I'm grateful to have been afforded an opportunity to come before you. Thanks to Dr. Sirohi, Dr. Anurag. Am I audible? So, surgeon's perspective in the COVID. So we as surgeons, before the COVID, we always saw ourselves as leaders in the medical community. We were always ready to respond to any type of medical emergency or disaster. We found ourselves always on duty. Always played a central role in managing the patients. So now what after the COVID? The anesthesiologists, the pulmonologists, the infectious disease doctors, the physicians, the critical care specialists, the epidemiologists, many more people, but not the surgeons. So the surgeons are not in the front line anymore. We are not needed and searched for in this battle of COVID. Patients are also cancelling their surgical appointments. In other words, COVID times is a war against the virus, rendering a surgeon almost least useful. Hence, we are facing a sense of frustration. Even the government gives us guidelines to postpone and curtail the elective surgical procedures. We are ourselves very apprehensive and afraid about contracting the disease. There are instructions that keep the surgical beds vacant for the COVID patients. So what the surgeons believe now? They are longing for helping the patients and their colleagues. This call alleviates our sense of uselessness. Now what we need to redesign our clinical daily work and the way we perceive our job. The reflection in our thoughts and actions is needed. I'll put some interesting data taken from the Indian Journal of Surgery, April, May, and June. 41% of the surgeons are into practice for more than 20 years. That is, all of them are nearing the age of 50. So make them more vulnerable for contracting this disease. 36.6% are into private practice at multiple hospitals at freelancers. 41% of the surgeons are practicing laparoscopy. Even the recent data from Commonwealth Fund found that the surgical specialties saw a 66% drop in outpatient visits and similar decline in their revenue. So see this graph will easily tell you that 41%, which I mentioned earlier, are laparoscopic surgeons. About 40% practice laparoscopy and open surgery, and 17% surgeons are purely open surgeons. In the pre-COVID era, those surgeons who were having a OPD of 20 to 25 patients a day are now seeing only 4 to 5 patient OPDs in the day. Those who were operating almost 30 to 40 surgeries a month, it has now reduced to 4 to 5 per month. 77% of the surgeons did not perform any elective surgery in the month of April, May, and June. This is interesting data. only 52% of the surgeons were using PPEs. Not many were using chemoprophylaxis in the form of HCQ, ivermectin, and other drugs. So 52% surgeons had a 75% drop in their monthly income. So 50% of the surgeons were resorting to online consultations. So this is a very interesting data. And see the comparison in this bar diagram. See the daily OPD is in blue, and after COVID, how it has drastically reduced. See the elective surgeries in the blue pre-COVID and the red after COVID was set in. However, the emergency surgeries graph is about 50%. It's better. So what are the recommendations? Not only the surgeons, other branches who use the operation theatre may also be benefited by my talk. The recommendations were that prefer open surgery to laparoscopy due to potential presence of the virus in the aerosol of the insufflated carbon dioxide. Choose alternative non-surgical therapies. I mean to say, use conservative treatments than to rushing into surgery. Those big procedures which require colorectal anastomosis should be avoided for the risk of leakage, spillage into the bed sheets, and then producing a big risk to the whole hospital and the healthcare workers. All non-urgent diagnostic procedures like laparoscopy and endoscopies were postponed. Emergency surgeries like acute appendicitis, which was taught to us to be operated immediately, had to now wait for 24 to 48 hours for RT-PCR report to come. And waiting led to many complications. Acute appendicitis could perforate. Small diseases like abscess, paraphimosis, and many other small diseases had to wait until the COVID report was available. So the patient suffering increased. And in some cases like appendicitis, the mortality was increased. So because of the COVID, we all hope that this pandemic will finish soon and will have a decreased impact on our health system. Coming up of telemedicine will be there. Many surgical outpatient visits will be managed by a televisit. The patient's lab and CT scan endoscopy reports will be seen and discussed over the phone or the internet. In big hospitals where oncology surgeries are being taken or organ transplantation is being done, they'll be handled, the tumor boards and the transplantation boards will be handled on video conferencing. So because of this COVID, emergency surgeries will be done strictly following some guidelines to avoid self-contamination or to avoid contamination to the patients by this virus. Communication to the patient is also a challenge. The near and dear ones want to know about the patient's condition, whether pre-operative or post-operative. So words have to be exchanged on phone. Because only a single attendant is now being allowed inside the hospital. So most of the information to the other attendants is passed on phone. So what are the questions which arise? Should we perform elective surgeries to prevent complications or avoid future burden of the patients till the end of the pandemic? Till when we can postpone these diagnostic procedures like endoscopy? I want to reiterate that gallstone disease is a very big entity in North India. I tell you, every city is performing almost 25 operations every day in North India. So if we start postponing these surgeries, there'll be a big backlog. And who will clear this backlog? Only we will have to clear it. So what we should do? So there are some guidelines which have been jointly issued by the American Society by European Surgeons and Association of Minimal Access Surgery India, AMASI, and IAGES. What do they say? They say RT-PCR is the test which has to be done in every patient before surgery. Elective surgery is to be avoided. Only emergency, life-threatening, and semi-emergency surgery should be posted for surgery. More important, keep the false negative rate of the test into account. Therefore, every patient should be considered a potentially infected patient, and adequate preventive measures should be taken. 30% of the RT-PCRs may give a false negative report. So this has to be kept into your mind. In an emergency, a chest X-ray or preferably a contrast enhanced or HRCT should be done to find what is the condition of the lungs of the patient. Always keep alternate managements into your mind. Many cancer surgeons are resorting to anterior chemotherapy or radiotherapy prior to surgery. Surgery to be undertaken only if it is a must. Now, what in the operation theatre? Most operation theatres have a positive pressure ventilation with a laminar flow, which prevents a non-sterile air to enter the sterile zone where the patient is lying down on the table and the operation is being going on. But this now makes the spread of aerosol faster. So now negative pressure ventilation is required to prevent COVID. The air conditioners should be started only after the patient has been inducted into anesthesia. And before extubation, 20 minutes before the extubation, the air conditioning should be stopped. Minimum personnel should be present inside the operation theatre, and they should be made aware of the possibility of viral contamination. Every hospital employee who is on duty must be aware that he can get this type of viral contamination. 1% hypochlorite solution is used to clean the OT. But remember, it takes 30 minutes for hypochlorite to act and decontaminate the surfaces which you have used on. All healthcare workers in the OT should wear adequate protection. They should be taught properly about correct method of donning the PPEs and removing them safely and how to dispose them of. Very important, surgical team should enter after 15 minutes of the intubation. All consumables and the medicine required should be available inside the OT to prevent exit of staff from the OT. No one should move out of the OT. The duration of surgeries should be kept minimum. Therefore, before taking a complex procedure, please think this in mind. There should be a gap of minimum of 1 hour between two operations in the same operating room. This is because you need time for the decontamination to be done. That's half an hour, I told you in the previous slide. And then another half an hour for all the getting your equipment and other things ready. The important exit sequence from the operation theatre once the operation has finished. The first to leave the operation theatre should be the surgical team. Then the patient should be extubated. Then the patient should be shifted out. Then the anesthesia team leaves the operating room. And lastly, the cleaning and the sterilization crew will clean the OT, sterilize it, and then leave. Some recommendations for those into laparoscopic surgery. The pneumoperitoneum and smoke produced with these energy devices like the diathermy are a potential cause for viral transmission. So you set your power settings to a low level, give short bursts of diathermy, and avoid charring tissue to prevent spread of this virus. The ports you make on the abdominal wall should be small and your trocar should be snugly fitting in them to avoid peri-trocar leakage of air into the operation theatre. The insufflation pressure of the carbon dioxide used should be kept to a minimum. Don't overinflate for your convenience. And while desufflating, all escaping gas and smoke should pass through an ultrafiltration system or through 1% hypochlorite solution. Use limited number of drains. So what the normally practice is, closing the ports, is putting a skin stitch on the port. But here a facial closure is now recommended, so that there is no escape of any gas from the port site. Few more questions come into my mind. Can telemedicine cover all the need of the recent post-surgical cases? Should we prepare the health system to face new global emergency? What after the COVID? As surgeons, should we reassign ourselves and our co-workers to cover urgently needed COVID-19 frontline? Or should the surgeons come to the front line? They are now in the back line. So what is the need for the day? The surgical community has to quickly respond to these emerging issues. Given the uncertainty of this COVID impact, over the next few months, the surgeons have to face this emergency with an even stronger and sound clinical judgment. As is happening, the surgical societies need to keep on preparing and reinforcing the guidelines to ensure the safety of the surgeons and the healthcare workers, and they have to be strictly followed. Now, delaying a surgery, which we always talk, indications to delay a surgery should be taken by a multidisciplinary team of the hospital, because this is a medical legal issue. If you postpone a surgery of acute appendicitis for a few days, the patient can perforate. The morbidity and even mortality increases, and this can become a medical legal issue later on. All patients, even if they are negative for COVID, should be consented for the risk of being harmed by coronavirus infection. A major effort is now required by these surgeons in this time of crisis. We should try to provide the best possible care to our patients, of course, with scarcer resources. We should try to develop new skills and respond day to day in this difficult situation, progressively putting in new norms for the old norms, and long-term plans for the potential next epidemic should be there. The surgeons need to be trained and play a central role in planning new strategies to fight possible medical global emergencies in the future. This is just a morale boosting. The clinical scenario in surgery could change in the forthcoming future. And I hope the surgical community will respond to this call. What about the postgraduate training in surgery? The current COVID-19 pandemic has led to unprecedented disruption in the medical training. There is very, very low exposure to specific clinical cases. So what should we stop, freeze, or continue training of our residents and fellows? So adopt e-learning, teleclinics, and teletraining. We should train our trainees with surgical skills through internet and videos, use of simulation technology. As for the pilots for flying an aeroplane, the same technology can be used for learning surgery. How can we ensure a high caliber of training during such difficult time? Now, some words about telesurgery care. This is required to reduce the limit the patient's unnecessary trips to the hospital and clinic. He may get infected or he may infect you. So telesurgery care provides better benefits to both the patient and the provider. To conduct the pre-operative surgical consultation for diagnosis, post-operative surgical consultations for follow-up, but patient satisfaction and the money spent has to be kept in mind. So digitization of surgical data will be necessary. Incorporating the radiology and the pathology into teleradiology and telepathology. Three-dimensional image reconstruction. Development of telesurgical applications. More and more robotic involvement if such pandemics keep on coming. But with this telesurgery care, the privacy is a very, very big issue. The confidentiality, protection of the patient's data is of prime importance. And this is also the right of the patient. So cybersecurity risk and secure websites are need of the hour. Now, a special disadvantage to a surgical patient because he has to send his image by telesurgery care and televisit. He will not like his image to be broadcast in the public. Necrotizing fasciitis in a female in a post-operative phase, carcinoma of the penis, a large incisional hernia, a carcinoma, fungating carcinoma of the breast operated. This is the follow-up. So these images will come in the internet. So the cyber security has to be very important, especially in telesurgical care. So what has to stay? Everybody has said social distancing protocols have to stay. Patients will have to be screened for COVID-19 before surgery as we are doing it. One thing has been introduced, the patient self-check of his temperature 1 week prior to admission every day. And then on arrival of the patient, again the screening should be done. So in the end, the surgical fraternity needs to keep abreast of the latest literature, safety measures during surgical procedures. Keep abreast with review articles, go on learning. This is an educational process. This knowledge must keep on evolving. Thank you very much.
Thank you, Dr. Jaggi. There are lots of issues in the surgical branches, and yes, you have rightly brought them to the fore. Thank you very much. I think our speakers have covered many important topics today. The new about the MSME by Dr. Nagpal, the consent topic by Dr. Ashwini Setya, and the cardiovascular effects, the infertility topic, and the surgical perspective. Now we also have our learned panelists, Dr. Nanda Sawant. He is a gynecologist from Maharashtra. Welcome, Dr. Nanda. Dr. Anurag Verma is a physician and medical legal consultant at Kashipur. Dr. Arvind Sharma, he is a physician and president-elect from Uttarakhand IMA. Dr. R.A.K.D. people here. I would like the discussion part in such a way that the audience gets benefited, though I think the speakers have covered the things very beautifully, but then also there may be some things which have been left. So I would ask Dr. Anurag Verma to start from the medical legal point of view. Dr. Anurag Verma, please unmute yourself. I would like all the speakers to unmute themselves so that there can be a healthy discussion. All the panelists, please unmute yourself. Dr. Arvind Sharma, please unmute. Yes, Dr. Anurag.
Yeah, I would like to ask Dr. Jaggi sir, one question. I have come across this term. He must be knowing about it. Sir, can you enlighten us of the term COVID fatigue? What is this and how it is important?
Okay, thank you, Dr. Verma. COVID fatigue is a very generalized term. This, as the name says, it is not the fatigue to us because of the COVID. It is a generalized term. A COVID fatigue for a patient is that he has stopped using masks. He is fatigued with using masks. He stopped using the mask. He started spitting on the roadside. So this is just an opposite meaning, COVID fatigue. Doctors, they have stopped wearing PPE kits in the operation theatre. They have stopped wearing PPE kits in the OPD. Just imagine, you can retrospect yourself. How many doctors are using PPE kit in the OPD now? I've seen them wearing a glove or even without glove sitting, putting a small mask, surgical mask and sitting there. They've stopped using N95 masks. So this is COVID fatigue. So we should not be affected by this COVID fatigue. Keep our tempo high and fight this disease till it is eradicated, and educate the patients also not to fall in the trap of COVID fatigue. I think that's enough.
I would like to ask one question from Dr. Sadana. What did you tell about this thing in place of clopidogrel? The drug is to be used. In what way it is superior to clopidogrel if it is of the same group?
No, sir. This clopidogrel is a quite old antiplatelet agent. The newer agents like ticagrelor and prasugrel have come into the market. But the reason is this, that the antiviral which we use for this treatment of COVID infection, they interact with both with clopidogrel. They decrease the bioavailability of clopidogrel in the body of the active metabolite, and they increase the bioavailability of ticagrelor. So both of these drugs have significant drug interaction with the antivirals which we use for treatment of COVID infection. That's why this prasugrel, this is also a prasugrel. It come into the market with the name of Prasita or Prax. So instead of using clopidogrel or ticagrelor, we should use this prasugrel drug apart from aspirin. But this prasugrel usually we cannot write in a patient who has to be treated medically. It has to be used only by an interventional cardiologist, because as per guidelines, prasugrel is not indicated for a medically managed patient. It should only be used in a patient who is to be taken for angioplasty only. So aspirin can be used otherwise.
Dr. Punish,
yeah.
My question is that you have had a patient of COVID, you have used low molecular weight heparin,
yeah,
and you are now to discharge the patient. Would all patients of COVID who have been in hospital treated either with oxygen or remdesivir require 4 to 6 weeks of,
no.
Or it will depend on the D-dimer value, or it will depend on some measurable objective?
So as such, not only the as per guidelines, the in-hospital low molecular weight heparin is advisable only in patients who are at risk of pulmonary embolism or developing DVTP on the basis of markers like D-dimer and IL-16 and other inflammatory markers which we use in while treatment of COVID infection. Only on those group of patients we should write this oral anticoagulant for another 4 to 6 weeks. Otherwise, this 5 to 7 days of low molecular weight heparin in hospital setting is advisable.
Dr. Kedia,
yes, sir.
You were asking something in the previous talk also about some cardiovascular.
Yeah. In post-COVID fibrosis, am I audible?
Yes.
In post-COVID fibrosis, what is the role of what is the role of D.H.M? Is that the people are using or not, when to use, when not to use? There are many confusion and controversy, definitely. Dr. Sadana or any person.
COVID pulmonary fibrosis, sir.
Yes.
So I'm not aware of that. I'm not aware of that, sir. I think Dr. Anurag Verma, I think he can answer this question, sir.
Dr. Arvind Sharma is also.
Yeah, Dr. Arvind can better.
Yes, Dr. Arvind Sharma, yes, sir.
Arvind, you mute yourself. Unmute.
Unmute. Dr. Arvind Sharma, you have to unmute. Yes.
I am audible?
Yes.
Hello.
Yes, sir, you are audible.
You are very good audible.
Start writing.
Internet is not good.
Let's go on to the next question, sir.
Sir, one thing, can I add some? I can share something?
Yes.
Hello, Dr. Sirohi. Dr. Arvind Sharma.
Dr. Punish, can I ask you one question?
Yes, sir.
In other respiratory diseases and other diseases, steroids are contraindicated. But in COVID, steroids are more helpful, much more helpful. How is it?
So I think this answer should be answered by some critical care specialist, but I think it's the role is the same. It has an anti-inflammatory action. I think I don't have any other explanation for this. The cytokine storm and all this inflammatory activities.
These steroids will prevent fibrosis.
Yeah, and as we see in other ARDS also. This steroid is given in most of the places. Yes, I think that will explain the thing.
And Dr. Punish?
Efficacy of these anti-fibrosis agents, this has not been documented well. It has not been proved.
But the effect of dexamethasone is much more helpful in the COVID patient, especially in the respiratory, when the respiratory tract is involved more, and where the patients are having the pneumonic infection more, where the dexamethasone is much more helpful.
Dr. Punish, one of my senior most anesthetists, he had bypass 4 years before, and he was very much asymptomatic, had fever, and after 5 days he was coming positive for COVID and expired. So patients who are having this bypass surgery 4-5 years before, they are having comorbidity more, like you said, 10% they are having high risk.
Yeah. That case fatality rate in a patient with underlying cardiovascular problem in the form of either old MI or post bypass, post angioplasty, or previous stroke, they are at high risk of morbidity also and mortality also. Yeah, this is as per the most of the studies conducted in the COVID group of patients, ma'am.
So what care extra they have to take,
They have to be even more cautious. The ones even if they are not having symptoms of respiratory tract and they come out to be positive with COVID infection, they have to immediately consult so as the antivirals or the drugs which are to be prescribed for this COVID infection, it has to be given as soon as possible.
He admitted in WOCAD the day he diagnosed, but still after 5 days he was no more. So I hope that was the comorbidity he had, that cardiac problem. So that must have deteriorated much more.
Yeah, ma'am. Yeah.
Dr. Jaggi.
Yes, sir.
Dr. Jaggi, your comment on my suggestion. We do elective surgery after the result of the COVID test is sent and the result comes on the 3rd day. Should there be not the quarantine for the patient till surgery is done? Because there are chances of exposure after giving the sample and up to the surgery period. Should the patient not go on quarantine?
You mean the patient is positive for RT-PCR?
No. We send the sample, RT-PCR, and wait for the result. And the result comes on 3rd day.
Okay.
To To avoid chances of exposure, the patient should be quarantined till surgery.
No, very true. We have a separate place for those patients who are waiting for the results. So they are put on conservative treatment if it is an emergency, like if say acute appendicitis. It will put into a place where those patients are kept who are awaiting the reports. They are not mixed in the wards.
No, my question is that if we admit the patient after the RT-PCR becomes negative, and we send the sample and wait for the 3 days and the patient remain at home. Only after RT-PCR
you mean
the patient.
The quarantine is done for a patient who is potentially positive.
Yeah.
No.
I don't understand why to quarantine the patient.
My concern is if you send a RT-PCR on the patient and it comes negative for that day test, not for the other 3 days for which we are waiting for the result. We should get exposure on those 3 days.
That's what I am saying. If the patient requires admission immediately, there has to be a separate area for those patients who are awaiting the report. So there is no need to quarantine the patient. You keep it in a place where those patients are waiting. Of course, there is the risk of cross-infection to those patients and to the health workers also. But this is a standard practice which we are following. Quarantine is done to a patient who reports positive.
No. My concern is that patient should, if he is at home for the wait of result of RT-PCR, then he should be at home for those 3 days.
Correct. You mean to say he gives his test today and tomorrow he gets infected somewhere else?
Yes.
Very true. That's an intelligence to be imparted to the patient to remain at home. Very true. That is true. So that he may not pick up an infection somewhere after giving his test.
Yes.
I agree with you.
Dr. Jaggi, this PCR report, how many days they can wait? Like patient, they take the report and go back home coming after a week or 10. So what's the point there?
We're not 5-10 days, ma'am. If it is supposing you are doing an elective surgery, you should get the PCR done and operate the same day or the next day when the report is there with you.
But many times patient do go back home and coming after a week, now I want to admit.
Then you can ask for another PCR.
That's true.
You can ask for another PCR. Of course, risk is for the patient, your risk, the health workers and the hospital.
I remember one patient, one of my friend, he delivered the patient. First, initially, the RT-PCR was negative, but patient had one spike, fever spike. After that, on the 4th day, again he repeated the RT-PCR, and later on the patient turned out positive.
Yeah,
this happens, of course. So that's what I told in my talk. Every patient should be considered a RT-PCR positive COVID, even if the report is negative. Due precautions should be taken.
30% or
what we are facing is one, a false negative report. Two,
exactly. That's what. It is a 40 to 50% false positive and false negative rate is there. Because no test is there.
When we are repeatedly doing PCR, if we get a positive report, patients are going for a second test outside our control. In case that comes negative, there is an issue which is raised with the hospital which has given the first PCR report. My point is, we have recently come across a case where a patient who was to undergo cesarean, PCR was done, it was negative, cesarean was done, she was discharged, went home, came back next day with fever and some ghabrat, admitted, died with COVID. Now that patient's relatives created a ruckus. The patient was negative for COVID when you took the patient in. And immediately after your procedure, now the patient has developed COVID from you. However much consent you may take, that doesn't absolve you of negligence per se. And when we repeatedly do, because you are saying now surgical guidelines, what we are seeing here, many hospitals have actually stopped doing pre-procedure, pre-elective, pre-delivery, pre-surgery COVID to safeguard themselves from this problem. They treat all patients as COVID, take all the precautions for all patients and do not go in for the compulsory pre-operative COVID testing. This is something we are seeing now in the past 2 weeks or 3 weeks.
But then you are defying the guidelines. They say that you have to do a PCR before it.
You have to do a PCR.
Nowadays, listen. Nowadays, we have started taking the consent, saying that at any time, even if you are admitted in the hospital, at any time you may turn positive, COVID positive. We never know because of what you are getting the infection. Either it is from the relatives or from the doctor or the nurses. We don't know. But you can turn positive at any moment. That's what. And the hospital is not responsible for this infection. That's what we are telling, and we're taking the consent.
Sir, a consent does not absolve you of an allegation of negligence.
Yes.
You can take consent.
Dr. Nagpal is saying right. I don't think this doing RT-PCR test before any surgery is mandatory in Uttarakhand at least. Dr. Arvind can tell it better. But I have not come across this thing that is pre-operative RT-PCR testing is mandatory.
Out 9 hospitals in Chandigarh, they are not doing compulsory PCR testing.
Yes.
Max is doing. There are hospitals who have stopped doing it for this reason.
There was a suggestion that when we take consent, we should get the patient right, that I am seeing that the due precautions are being taken by the hospital and the staff, and I am satisfied with this precautions taken by the hospital. And if in spite of that there is some COVID infection, that I will not held responsible to the hospital.
Yeah, this was added in consent form.
Get it written in the consent that the patient is aware that precautions are being taken to prevent COVID from happening. You cannot force a person to write and say, I will not hold the hospital responsible.
Okay.
You can ask them to sign everything. They will not hold the hospital responsible for anything which goes wrong.
Yes.
So a consent like that under duress is an invalid consent.
But he can at least write that he is satisfied with the precautions being taken.
Yes, that's a good idea. You can have boards outside which can where it is clearly written what kind of precautions need to be taken on the patient side, what kind of precautions need to be taken on the relative side, all these things, and you would be in a position to prove in court tomorrow that you have taken adequate steps to prevent cross-infection. But then all this does not stop an XYZ from taking you to court, stating what you have done is not correct.
And then what should be done if a patient has come with a negative RT-PCR report pre-operatively? In that case, what do you suggest?
तो वो तो आपने इलेक्टिव काम तो करना ही है. अब वो नेगेटिव रिपोर्ट लेके आया है, जैसा मैम ने कहा कि अगर वो रिपोर्ट
we should not get it done.
तो वो देखो ये we are going to see cases.
Yes.
Believe me when I say this, in the next 6 months to 1 year, we are going to have cases in court where patients are going to say that doctors have given a false positive report, or I was negative and the infection was given to me by the hospital. Both sides.
See, there are 40 to 50% false positive is there and false negative is there. You cannot depend on one test. At least you do a rapid antigen test or antibody test or a rapid RT-PCR.
No, I don't agree. Rapid antigen test is not a test for people to do. It is for the community to find out some positive cases. If it is positive, you have found a case of COVID. If it is negative, it is not necessary that he is not having COVID. 50%.
Not at all. It is not at all. It is considered, but RT-PCR is definitely considered.
Yeah, RT-PCR is recommended to be done.
Yeah.
Dr. Sir, at Mumbai Fortis, what we are doing, we are admitting patient immediately after doing the antigen test, keeping separately. And once the COVID report is coming RT-PCR positive, then we used to shift in the normal ward or ICU. That's the one way. But for emergency, like I had last week one ectopic pregnancy 4 gram, and we were not having any time to wait for her. So we did immediately antigen test, HRCT, and then we have taken in the OT immediately.
Exactly.
It was,
You did.
4 gram we cannot wait.
You did the HRCT.
Yeah,
and of course, then it's fine. You took
so we have to just see the patient condition, see what we can afford immediately, whether we can wait or no.
Very true.
I want to ask one question from Dr. Sushma.
Yeah.
That you are going to do these type of procedures for infertility in the couples who really need children.
Yes.
But what are the recommendations or guidelines for you in this era of COVID? Whether you are suggesting these couple to wait for some time, or
no, Dr. Anurag, because we are not having any data, what effect is going to be on the fetus first 4 months in the COVID. So we are just avoiding all the infertility, IUI and IVF cycle till we are not sure of what effect is coming in the pregnancy. So if they used to conceive naturally, then we used to do the close follow-up. But all procedure we are just keeping on hold because we are not having any data what it is going to affect on.
Even after 6 months, what is the fibrosis and what will happen to the lungs also you never know after 6 months. But still we have to wait for 6 months after the infection. Means what is the condition of the lungs?
Dr. Sushma, I would like to ask a medical legal question in IUI. If there is a donor sperm, is the name of the donor sperm being told to the recipient?
No, not at all. Because we have to take the semen from the semen bank only, who is the authorized semen bank. We cannot take from any known family person or the friends. So whether it's a oocyte donation or semen donation, we have to take from the bank only. We cannot tell the patient. We used to give the report, semen report, all the infection report to the patient, but we cannot tell the name of donor.
Sometimes patients relative, in-laws, and they suggest the doctor हमारे इसका देवर का ले लो, इसके देवर का ले लो.
That's not correct.
It is not correct at all, and not visible also.
Okay. Dr. Jaggi?
There's a question to Dr. Nagpal. Yes, he is very much there. Sir, any difference of spread of COVID in upper GI and colonoscopy? How do you risk of spread?
What we have started doing is we have modified the way we used to do endoscopy. There are hospitals which are doing a compulsory RT-PCR before even an endoscopic procedure. We are not doing that. We are taking extraordinary precautions in all patients in whom we are doing upper GI endoscopy or colonoscopy. Anyway, for more than 3 or 4 months, all procedures were on hold. Only very select procedures were being done, which was a bleed or something like that. But a bleed in our case, you cannot wait for an RT-PCR report. You have to go ahead and do whatever is needed to be done. So effectively, what we have found the middle path is that we are not going for RT-PCR. We do the procedure if it is required, postpone it if it can be postponed, and while doing the procedure, take all possible precautions that you need to take if you are doing a procedure in a COVID patient.
My question was, sir, that if you do a upper GI endoscopy or you do a colonoscopy of the same patient I'm talking, what more risk is colonoscopic
Upper is more risky.
Upper is more risky.
COVID is concerned.
As far as COVID is. That's what
as far as COVID is concerned. Okay. Lot of people have devised various techniques with which it is being said that you can reduce the spray, you can reduce the droplets, but effectively everybody has to adapt to the scenario which is there now.
I was in a influence that in colonoscopy you have to insufflate a lot of air to blow up the colon to visualize. So that has to come back again, and that can spread.
So ultimately, how does that come back? It comes in the suction.
Okay.
It depends on how you do the colonoscopy also. Ultimately, the way we do is if we insufflate, we also do the suction, and all the suction is going to go into the suction machine. It's not coming into the atmosphere around.
Your periscope leakage is not there.
No, periscope leakage is very little, and that too mostly when you are just coming out. When you just come out of the anal verge, at that time there will be some flatus, but you can't stop people from passing flatus while sitting in your reception area also.
Very true.
So ultimately, you have to learn to live with this disease. We cannot make it impossible to work and impossible to treat our patients. Yes, I don't say that we should take off our masks or we should not take the precautions which are necessary. As far as possible, do the work safely, as far as possible, but do not go overboard also.
Very true.
Dr. Sushma, are you listening?
Yeah.
You have told us right semen bank. From where we get the authorization? Is there any body like blood bank authorization or is given from the CMO?
Doctor, your voice is breaking actually.
We are not getting it properly. Yeah.
Dr. Bhatia ka audio thoda theek nahi hai.
Dr. Bhatia, you can use your audio system. That will be better.
Dr. Bhatia has asked this question that how do you get permission for semen bank?
This like blood bank, doctor, we are having the few rules from the government and you have to inform them. So you have to make proper like blood bank. We are having government rule for the semen bank also.
Which is authority?
Authority. Which is the authority?
Government. NARI is there, so they used to give the permission.
Government of Maharashtra.
Government of Maharashtra, there.
Health Department, Government of Maharashtra. So, all the panelists, I would like to ask a question. What do you see the type of practice from 3 months from now, say January 2021?
The roll up.
What type of practice will we be doing after 3 months?
I talked about just now. Anurag had asked me the question, corona fatigue.
No, that is okay.
So everybody is now fatigued of this corona. They want to come back to their normal this thing. So due precautions have to be taken, and we have to come to the normal stream and start our work as we used to do earlier.
Dr. Arvind Sharma. Dr. Arvind Sharma, can you hear me?
Yes, sir, I can hear you.
Okay. Dr. Arvind Sharma is seeing a lot of patients here. I would like to know from him what special precautions and how he is managing them.
Sir, on the main door, we are having our guard and he is asking everybody to wash his hand outside the nursing home, and the person is coming with sanitizing his hands. And when he enter in the reception area, we have developed some screens on that reception area, and there is a screen in between me and my patients also. And we avoid touching patient, but when it is compulsory, then we have some that kind of screen between me or patient, and I go with my stove through this screen. And after the patient, I sterilize my hands and my stethoscope both.
Okay.
And my staff is using mask as well as a face shield also. Touch wood, there is no infection till date in my hospital, and we have admitted, unfortunately or fortunately, 20 to 30 patients of COVID. When we got investigated, they came positive and we transferred those patients to the hospital setups.
COVID hospitals.
Yeah.
Okay. So the main
even we are taking the notes from the patient, currency notes. They should be sanitized properly, and then you can accept those notes, currency notes.
They are showing the notes. They are showing the notes on reception. We are putting those notes in some collection box.
Bag.
Yeah, we are not touching the notes.
We are following this.
You put them in a good luck.
But the viruses will remain for 36 hours, for almost 4 days.
Sir, we are getting then hot press over those by one of the compounders. After
you can have more than one good luck, and you touch them after 3 days.
Yeah, exactly. The daily collection, you can put it in a one packet. You put it, and after 4 days you can collect that collection.
Yes.
So now in the reception, the compounders are standing with a dabba. Put the money here.
Yes.
What a scene created. Eh?
No, that's very important, because cash is there to be handled, and it is not in big cities. It may be there that the people are having electronic transfer, but in small cities, cash is there. So
And even big city, most of the patient they come with the cash only. Hardly few person they come online. And second thing, on your mobile, on your table, everywhere it is going to survive. The news was there on the mobile is for the 28 days. So you have to clean your mobile, everything every day. So not only note, everything surrounding us is having that problem.
You can stop seeing the patients in your OPD. Devise a second room in just near to your OPD. Go there with all the history on your mobile, and then examine him for the least time, and then come back, wash yourself, and then give a prescription.
At the entrance only the staff is, at the entrance only the staff is taking the pulse, SpO2 and everything. And before entering the patient, the patient should wash their hand with the sanitizer at least. And the same thing, they can take out their shoes outside your OPD, and there is a doormat where on the doormat also you put the sanitizer. The patient should clean their foot on that, and then they enter in the OPD.
But Nanda, in gynec, without examination, you cannot do anything. You have to examine every
You
patient.
have to examine each and every patient in obstetrics and gynec.
Yes,
without seeing the patient is not satisfied, and this is 101%. Even if you put a curtain in between the patient and doctor, that is also not satisfied. You satisfy the patient. When the patient has to lie down on the examination table, you have to examine the fetal heart sounds and everything. But you have to, same time, you take precautions yourself also. You are daily putting the PP kit and face shield and mask and everything, and gloves.
But how many person in OPD are putting this PPE kit?
Nowadays, see, all the staff who are attending OPD, they are putting the PPE kit as well as the face shield and simple mask as well as N95, and over that a shield.
And how are you disposing of so many PP kits every day?
No, there are reusable PP kits are there. Reusable PP kits are available now.
You are autoclaving.
You can sanitize those PPE kits in a hypochlorite solution, but every 4th day that turn comes. That means one staff uses 4 PPE kits.
Okay.
I have put in exhaust also, got fitted an exhaust also, which throws the air away from me. Whenever the patient comes and sits, on the top of the patient, the exhaust is there. And that is when it is blowing, it is putting away the air.
When you are sitting in a OPD, all the windows should be open, door should be open. The AC is on your head, that the blast should go away from you.
Yes.
Yeah.
So, if anything is not left to discuss, we should close the meeting. What do you feel?
Fine, thank you.
Yes.
Okay, so I thank each and every one of you for the nice meeting. You came on my request. Thank you very much. Dr. Nagpal, Dr. Sushma, Dr. Sawant, Dr. Jaggi, Dr. Punish,
Thank you,
Dr. Kedia, Dr. Arvind, Dr. Anurag, and my special thanks to Dr. Neeraj Bijlani, who has made this live, and Dr. Ashok Shyam. He's not there today, but he made all the arrangements for us.
Thank you, sir.
Thanks.
I'm very thankful to Dr. Arvind Sharma, who joined this meeting when I called him.
Thank you. Welcome.
Thank
I'll
you.
call you in
sir.
next meetings
Thank
also.
you,
Thank
Ashok.
you,
Thank you,
thank
Sushma
you.
madam. At the time, immediately she told me, Nanda, you have to attend. Yes, I attended.
Yeah. Thanks, Nanda, and thanks everyone.
Thank you, sir.
Okay.
Thanks,
Thank you,
Rishi.
everyone.
Thank you, sir.
Thank you.
Bye.
Thank you, sir.